and with the City of Manchester, and is currently the Public Health Director for the City of Manchester. Anna Thomas is a nationally recognized leader known for her commitment to neighborhood health, equity, and community well-being. Please join me in warmly welcoming Anna Thomas.
Good morning. Oh, my goodness, I'm taking the mic off already. All right, so let me just get my slides advanced. Okay, so as Gillian mentioned, I am the Public Health Director of the City of Manchester. It's really serendipitous that I'm also here as a cancer survivor. So many, many years ago, when I was fresh out of treatment, I actually spoke in front of this exact same audience. And it's amazing because I'm now celebrating my 12-year cancerversary, cancer-free. Thank you. I feel very, very blessed. And I think, oops, let me just jump. That's my title, there you go. So other things that sort of define my life is that I also am a mom, I'm a wife. I have served in the military for 16 years and got out at the rank of major when I gave birth to our first son. And I'm also somebody who is very realistic about the work at hand. This is so huge for the state of New Hampshire to have us back in a room together. We all survived a pandemic, right? And we're all coming off Zoom meetings and not seeing each other in person. And I'm going to talk a little bit about how important it is to have fundamentally strong relationships as our base in order to improve health longitudinally. So one of the things I wanted to do, and this was when that was my first chemo treatment, is that picture. It's the only bald picture I have, actually, of myself. The rest were in hats and scarves. So we know that we're going to do a little bit of an exercise. If you haven't already scanned the CR code, you've got it at your table. But we want to do a little bit of a check for understanding exercise. And the reason why I want to do this is to kind of get our day started, to frame the rest of the work of the day, but also just to sort of get a check for where we're all at. This is something that we have done in the military quite a bit because I was assigned to an infantry regiment and we were all very sleep deprived on most occasions. And I had to try to inspire the troops to answer questions and participate in large gatherings very similar to this. So the way I did it was I actually incentivized them with scratch tickets. So what we're going to do is we're going to do a similar exercise, but not with scratch tickets. We're going to use raffle tickets. So here are the rules of engagement. So you have to raise your hand first. Don't blurt out an answer. This can get very cutthroat, so I'm trying to get out of it. So you have to raise your hand to answer a question. No answer is incorrect. It's okay if it's not right. Just try and think it through and give me a response. It's okay, you'll still get a raffle ticket. Also, if you feel that you are acquiring too many raffle tickets, you can share them with other people or at least try to give everyone a chance to answer the questions, okay? We good? All right, so I have helpers in the room who have tickets, yes, in hand. Okay, so first question, on average, how many new cases of cancer are diagnosed every year in New Hampshire? How many new cases? It's okay if you answer incorrectly. Yes, sir. About 8,600. That absolutely is a raffle ticket worthy. I'm going to up it by about 300. So on average, it's about 8,900, but you are spot on. What a great first response. I'm impressed. 8,900 new cases every year. On average, how many people do we lose to cancer every year in New Hampshire? It's a tougher number, I know. Come on, no guts, no glory. I know it's early. We got to do this. Yes, please. I'm sorry? 4,500, a bit high, still raffle ticket worthy, yes. Still a bit high, yes. Okay, I'm gonna go close to that, so 2,900 people every year we lose to some form of cancer in the state of New Hampshire. I wanna dedicate today to those lives we've lost, to those who are fighting, to those who have been caregivers of our cancer survivors, and also to the over 1 million residents in the state of New Hampshire who hopefully we can prevent from ever having a cancer in their life. We know it's the second leading cause of death. So odds are, at some point, if I counted off now, 1 in 3, odds are some of us are going to experience this in our lifetime. So, of the new cancers diagnosed in New Hampshire, which cancer is predominantly diagnosed at a local stage? So, early on, the earlier, the better. Yes, all the way back there, yes. In the green dress. That's incorrect, but I like the passion. Yes, right there. Incorrect. Okay, now I'm biased because this is going to be my partner in crime later on. You're absolutely correct. So melanoma of the skin, so yes. The two you've pointed out are kind of in the middle of the field. I'll show you that on the slide. So yes, melanoma of the skin, and I'm going to talk about the stage of cancer diagnosis too, because that's commensurate often with whether or not people are accessing care on a regular basis, and are we getting to these cancers as early as we can, because we know that increases the survivalhood, right? So, I'm also going to talk a little bit about the goal of happiness and sense of purpose. You're probably wondering, what does that have to do with cancer? Well, I'm going to share my own life story when we get to that slide, but research has shown what are the 2 most important years when happiness peaks in life? What ages are the 2 most important and the highest peaks of happiness in our lives? The 2 ages. Let me get through. Yes, ma'am. 47. I need 2. 47 is incorrect, but that's okay. Give me another one. 2. So it's, well, so good. So that's good. It's actually 23 is one of the peaks. What's the other peak back there? 50. A little far off. Go a little older in the white. Very close. 69. So 23 and 69 is what the research shows is when we peak in our happiness. There's a whole bunch of factors that roll up into that, and I'll talk about that. Everyone's like, really? So, I know. So, okay. So, excess body weight is linked to an increased risk of how many types of cancers? Yes, in the back. Excellent, spot on, 13. We have a winner, all right. So another interesting fact, what is the median age of cancer diagnosis in New Hampshire? What's the median age? What's the average age? Yes, all the way in the back. Little young, good try. Yes, right there in front of, right there. Little higher, keep going, yes. Very close, 67. Is the average age of cancer diagnosis. And I want you to think about that because we're going to talk about prevention. We're going to talk about where are these opportunities for us to be most impactful in the lifespan. So keep that in mind, bank that. What % of cancers are caused by harmful mutations that are inherited from a person's parents? What %? All the way in the back, yes. Yes. Very good, 5 to 10%, depending on which study you look at. Excellent. What % of men and women will be diagnosed with cancer at some point during their lives? What %? Yes, all the way in the back in the black. Little high, yes, in the purple. That is incorrect, little bit high. Yes, all the way. It's close, 39%. So 39%, yeah. So it sort of marries what I was saying earlier about the 1 and 3, depending on which study you look at. Heavy or regular consumption of what product increases the risk of developing cancers of the oral cavity, pharynx, larynx, esophagus, liver, breast, colon, and rectum? Yes, all the way. Yes, excellent, alcohol. We often forget about that as a driver. So what is the number one modifiable risk factor for cancer, and by what percent? What's the number one modifiable risk factor? Yes. So be more specific. Incorrect, but that's okay. Yes? Excellent. Yeah, so tobacco, and it has sort of a weight in the prevention field of 33%. So it is one of the, in epidemiologically speaking, and that's really my background, one of the strongest correlations to disease processes is this connection of tobacco use and lung cancer. There's really nothing stronger in the literature, and it just shows that cause and effect. So the number one thing, when you look at it proportionate to all others, is if we can eliminate that from someone's lifestyle behavior, it's going to increase their chances, even after they've been diagnosed for cancer. So this is a really important one, and I'm going to talk a little bit about this as well. I just had my annual checkup with my oncologist, and I told her, hey, I'm going to the New Hampshire Cancer Partnership. What do you think I should tell them? What's important? And she said, just tell them to exercise. Number one for her was exercise. And it's not just exercise in the prevention of cancer, but it's exercise in the reoccurrence of cancer. So after I was diagnosed, I did some clinical trials. One of the studies I was part of was actually an app that they were testing out for cancer survivors, and it was tracking your exercise because it was essential for cancer survivors to have a certain level of exercise every week following that diagnosis and treatment in order to prevent the reoccurrence. And this is something that they really harped on when I was going through treatment. So how much physical activity is recommended to prevent cancer or reoccurrence of cancer, especially among cancer survivors, breast, colorectal, and prostate? How many minutes of moderate to intense aerobic activity every week? Yes, ma'am. I'm sorry? 150, spot on, love it. So 150, and you think about that, have you gotten 150 minutes this week yourself? It's always good to start with yourself because that's going to help you encourage this in others, right? If you haven't gotten that 150 in, and it might be 20 minutes in a day, 20 minutes in another day, it's really the collective of the 150. Okay, name some examples of viruses and bacteria that can cause cancer. This is my world in local public health. Yes, with the white. Yes, very good. A bunch of them. A few more. HPV, yes. Excellent. Hep C, Hep B. Anyone else? Yes. Sure. All right, I'll take that. It's not on my list, but I'll take it. All right. So lastly, and this is what I hope is one of the take-home messages about today, when we talk about resiliency. So I'm actually doing a course right now with Dr. Waldenberg, who is the author and the lead study at Harvard Study of Adult Development. It's one of the longest standing studies in the world on the science of happiness. So he's got a great book that's out, not to plug it, but I'm actually reading it right now. It's called The Good Life. So from all of these years of research that he has done, and they've studied people from all walks of life, all ages, and even generationally now. Now they're actually studying the kids of the study participants when they first started the study. What is the number one fact that contributes greatest to our health and happiness? It's the number one thing, all the way in the back. I like that, and I'll talk about that. It's not exactly gratitude, but close, yes? Yes, I love that. Yeah, so strong relationships and connection to each other. That was the one common denominator among all those who have lived the longest in the study and have had the most happiness in their life. So something to think about. How do you build strong relationships in your life if you don't have them? What can you do today to further that in your life? Because when it all is said and done, and they interviewed a lot of people at the end of life as well, that when they were asked about what they were most proud of or what they were most happiest about, it had nothing to do about their careers or how much money they made or the material possessions they owned. It was about their family. It was about their friends. It was about the relationships that they had in their lives that gave them the most joy. So let's dive into some slides. And I don't want to PowerPoint you to death, but I do want to at least, again, let's ground our work today in just some factual information. How many of you seen this before? Social determinants of health. Okay. So this is the Robert Wood Johnson Foundation's body of work where they have looked at years and years of research trying to understand what are the most significant drivers of health, not just cancer prevention, but just overall health in communities, which is where I spend a lot of my day. Every day I wake up and I'm worried about these drivers. So what's interesting about these, when you look at them, they're weighted. So it gives you a sense of, okay, if I spend more time in modifying someone's health behaviors, I know that contributes to 30% of our health status in a community. Where if I look at other drivers like social and economic factors, 40% of our health is driven by social and economic factors. And if you notice, the clinical care only defines 20% of our health status. So we can have outstanding health care, which I truly believe we do, and many of you are providers of care, which is outstanding, but we're not going to measurably improve health unless we go to the 80%. So it's not uncommon for me as a public health director to spend time at tables around housing, for example, or the educational system, because I know that if we can make measurable improvements in those spaces, it's also going to, down the road, measurably improve health overall. So it's hard to get your arms around it that that's where you find the solutions, but it's weird, and I've proven this over 31 years of doing this in Manchester over and over again. So I bring it forward because that's kind of the framing of how we look at health, right? The Institute of Medicine defines health as the ability to function in the face of changing circumstances. So you could live with disease like cancer and still be considered healthy because you have an ability to function in the face of changing circumstances, which to me is actually the definition of resiliency. So the next kind of framing, again, and this is sort of how we've organized our day a little bit. This is actually adapted from Brown University. And this kind of gives you the cancer control continuum. And it's where we all sort of spend time in each of these buckets. So some of us really are on the front end of this, right? Understanding the etiology of cancer and what are the causes and things that we need to define so we know how to intercede. And then a lot of us want to be in the prevention space, right? That's ideally, we don't want to see any cancer from occurring, but not all cancers are completely preventable. Certainly a lot of them, though, are influenced by the things that we can modify. So prevention is powerful, but it doesn't just stop there. Clearly, we have to have early detection, as I mentioned. We want to get to people as early as we can in their diagnosis. And certainly treatment changing all of the time. I mean, it is amazing how the field and the body of literature around treatment modalities is just busting at the seams. And I'll tell you, when I was going through my cancer treatment, what I experienced was very different than those who were 10 years before me going through cancer treatment. And I guarantee you right now, what people are getting for treatment for my exact same diagnosis is probably different than what I had 10 years ago. And that's a good thing, right? We are learning and we're growing and we're getting smarter about how to attack this in the population. And then we'd be remiss if we didn't mention survivorship, because ideally we want to get everybody to that end game, and that also includes the caregivers of our survivors and those actually going through treatment. But there's lifelong needs as well in survivorship. So that is its own domain, and we'll talk about that today. So here we go. Good news, first and foremost. So I also didn't put in my bio, by the way, that my dog's name is Blade. We have a dog named Blade. Everyone else put the dog name in their bio, and I didn't do that. The reason why is because we're a big hockey family, and I am a hockey mom. So I'm one of those really annoying moms in the stands yelling for the kid, you know. So these are little things from my children and actually one of my nephews. When I was going through cancer, my kids were 5 and 8 years old. So I'm trying to shepherd them through the experience, losing my hair, being sick, all of those things. And here are my kids who are actually more resilient than me and actually teaching me about how to face it. It was amazing, even at the youngest of ages, how they learned what it meant to see somebody suffering and how we could best help in those times of need. One of the greatest life lessons, not that I ever want to encourage it for anybody, but for my sons, it will stay with them for the rest of their lives. That is a permanent imprint, and it helped them become more compassionate people. So if there's any silver linings to cancer, I always try to find them. That's one of many. But the good news is we are seeing survival increasing incrementally year by year. That's exciting. And part of it is because we are getting better at treatment. We are getting better at early detection. The not so good news is that we're seeing cancers in some cases. That's coming up. This is actually just a snapshot of survival trends by cancer, and this is just different points in time. And I'm happy to share any of these slides for anybody who wants them or can use them for themselves. So you can see what I did was sort of flag onto the side. The greens are the ones that are doing really, really well. We're doing much better at breast cancer. We're doing much better at prostate cancer. The ones that are a little more challenging, that are either kind of leveled off or they're decreasing in survival, is urinary bladder, uterine cervix, uterine corpus, and larynx. That is kind of, as we look at that over time, we have to ask ourselves, what could we be doing differently in those spaces? And we'll talk about that as well. So just to kind of further the not so good news, we know that the CDC is predicting cancer incidence is going to increase by 50% as a result of the aging population in the years to come. And essentially what this is showing you that over time, we're predicting that because people are living longer, which is a phenomenal thing, but people are now living longer with chronic diseases, and in some cases, multiple chronic diseases, and cancer might be one of them. So as we push this out, you're going just to have more people with cancer diagnoses. It may not mean we have more cancer per se, but we have more people surviving and living longer for a whole host of reasons. So it's something to think about in the years ahead, that we're going to have generations in front of us that we're going to have to care for. So the population is going to continue to grow in New Hampshire, and this is just to give you sort of a weighting of that and projection of that. So this brings you out to 2050 all the way to the right. So the blue and the orange are our population projections for 65 to 84, and the orange is the 85 and older. And again, we mentioned already the average age of a cancer diagnosis is 67. So it's important to think about, because it sort of changes how we approach things, maybe at a population level, and how do we get ahead of these trends moving forward. So I was the one, when we say 1 in 3, 1 in 8 women will be diagnosed with breast cancer over their lifetime. I was the one. These are sort of the odds that you can see by cancer, and it ranges from birth to death. 1 in 8, certainly for breast cancer, but prostate is also 1 in 8 for men. But others have kind of a greater range. Lung and bronchus, you could see, is 5.8, so 1 in 17. And I think that is something that, we need to talk a little bit about too, because we talked about how preventable that is, especially if it's correlated to tobacco use. What could we be doing differently? So I was the one, but at the same time, because I live prevention, there's a power of the promise of prevention. And this is where, hopefully, we spend a lot of time today, because we want to proactively do as much as we can. And it might be caring for cancer survivors, but it also might be preventing cancer in all communities as much as we can as well. So I spend a lot of time in the bottom part of this schematic, which is kind of the population base. The top base is what we do on the individual level. They all roll up into those modifiable risk factors that you already mentioned. And this gives you sort of a weighting, and this is where that 33% of tobacco comes into play. But this gives you a weighting of how many of these cancers are attributable to these kinds of lifestyle factors. And that's helpful, because then I can say, all right, well, if 33% is tobacco, we need to do more to support our tobacco prevention program in the state of New Hampshire, who I know is here today, and we never do that. We're horrible at that, but yet it's so preventable. And we don't do enough we forget about tobacco because we say, oh, that people aren't doing it anymore. There's vaping, whatever. It is still very real. I will tell you, in the city of Manchester, it is amazing how many people are still smoking. I don't even know how they afford it. But we see it highly concentrated in our most impoverished neighborhoods in the city. So it's not even citywide, it's highly vulnerable populations. It is amazing how many people are still smoking. And so much that we've learned over the years, but yet it's still very real. So, because I love the tobacco prevention program, I'm going to show and shout out to the effectiveness of their work in the state of New Hampshire. This is what happens when we actually work on something collectively and work hard at it. We're seeing a reduction in adult smoking prevalence. This, as if you've never visited the New Hampshire data portal that Health and Human Services has, you can draw down this data for your own community or your own region. And I encourage you to do it if you have questions about how does this pan out for you or where you live. So what's encouraging is we're seeing a decline in tobacco use. That's what we want to see. I remember one of my roles in the military was I was the head of the medical command, the operations officer of the medical command in the state of New Hampshire. And we would do a lot of bringing in processing and out processing as soldiers were getting deployed. I was amazed at how many soldiers were still smoking, but even to hear from some of our veterans, much older, because I worked at the VA, it was fascinating to me that we actually put cigarettes in C rations, right? We issued it to the soldiers. It's one of the reasons why lung cancer went off the charts, because we were literally giving it as the same C ration that their food was in, and we're giving them cigarettes. And that's what caused a lot of the addiction in the early ages. But we're fortunate where things are changing for the better, but it doesn't mean our work is done. Now, the not so great is the excess weight and obesity. This is a huge driver of a whole bunch of poor health outcomes, not just cancers. And this is what we have to be mindful of, because this really is correlated to inflammation and all of these other things that we know in the research is bad for cancer, right? So excess weight, obesity, again, this is only the adult population, but we are seeing it even in the youngest of populations in our schools and in generationally seeing young people being raised eating unhealthy. And we all know that food is medicine, right? And that it is hard to change those behaviors once somebody has acquired those behaviors. Everybody, if you've not yourself ever gone through it, I certainly have, trying to lose weight, gain weight, lose weight. I mean, it's a constant battle, right, to maintain a healthy weight. But it's so important because it's one of those big, big drivers that we could do something about. And then certainly physical activity. So this, I'm going to channel my oncologist about this. This is the blue and the green. What's a little confusing about this is two different databases. So there was a new database that started right in the middle. So it's a new data set, so that's why they separated them. But for New Hampshire, what I don't like about this graph is the fact that we've kind of plateaued in physical inactivity. And it's one of the areas that it makes you question. Certainly, we have become a media frenzy, electronic frenzy society. Like, how often are we all on our phones? How often are we sedentary? It's much easier to be sedentary than to be physically active. So we're not making a dent in this space. So I'm going to channel my oncologist to say if there's one thing we all really need to harp on, it's physical activity. And that's even after a cancer diagnosis. Bronwyn was great to share this with me from the New York Times just this week. And there's a study that they were reporting out on, and they're saying researchers find causality between an aerobic program and a longer disease-free life, and it's about exercise's role in cancer survival. Yes, ma'am. Okay. Ah. Yes. Right. Yes. It's an excellent point, and I think that's what's happened to a lot of people. It's the work-life balance, right? We're all working a million hours. I know I am. And then I'm trying to juggle a life and a family. And when am I going to fit in physical activity? And quite frankly, when I get home from work, the last thing I want to do is go work out or even go for a walk. And I just want the dog to go walk himself. Like, seriously, like I don't, and I hate to say it, I would much rather check my phone or go on, Instagram and see what the latest trend is, or, it is a horrible toxicity that we've acquired to become that. It is really hard, and I think that's what explains some of this. It's really hard to break out of that pattern, and yes.
But also not having that assistance from your employer, from your
right.
insurance company, incentives to go out and do this, when it's going to benefit them as much as it will us.
So bring that thought to one of our breakouts, because that's an opportunity, right, for intervention. We can work with the insurers. We can work with employers on worksite wellness. We could work with our Chamber of Commerce. We could do more, just like, we went through a wave in the city of Manchester of becoming recovery-friendly. We wanted recovery-friendly workplaces. Why should we not become physically fit workplaces? Like, why are we not encouraging that, certifying workplaces to encourage physical activity, giving space for employees to actually build that into their day? Whether it's a quick exercise routine at your desk, there's things you can do, or having a working walk together. Sometimes employers will institute something like that. They'll allow employees to go for a walk and actually have a working meeting. We actually brought in treadmills into my department for my employees because they were all working such crazy hours, and I just encouraged them to get on the treadmill, even if it's for 15 minutes. It's more than what they were doing before. So I love that. So bring that, because that's where we want the answers to come from. You are absolutely spot on. Yes, ma'am.
So we brought up the fact that we wanted like the treadmill desk things.
Oh, yes, yes.
And we were shut down and told that it was a liability.
It is a liability, yes. I would say the same thing. I agree with you, though. I wish I could, but, I have seen it all, and I just know my employees, and undoubtedly at least one of them is going to send themselves off that thing, and then I'll be paying workman's compensation, and yes. But there's nothing to stop getting treadmills in your workplace if you can find a room and just set it up. We actually had ones, one of the great places to go is with your fire department or your police department, because they're always turning over their exercise equipment. They have to get new equipment. So they're the ones who actually got us the equipment. And I just had them move it over to our place. So there you go, little nugget. So let me give you one of the stats, and I just love this kind of research that's coming out. Participants in the exercise program had a 37% lower risk of dying and a 28% lower risk of recurrent or new cancer than those in the control group. So this is one of many studies, thank you for bringing this in, that's just reiterating what we probably already know, and it's just about how do we implement this in our spaces and our lives. So let's talk about excessive alcohol use, another area that we don't like to talk about in New Hampshire because we make so much money off of it. You could literally go anywhere. I will tell you, in Manchester, we went through an exercise, just as an example, of mapping out all of the access points for liquor establishments. And the reason why I was doing it is actually what the research shows is the more liquor access points you have in a community, the higher rates of child abuse and neglect you have in those same neighborhoods. So that's why we were doing it. But what it taught me and showed me was there was not a block in our city. The city's 33 square miles. You could literally go anywhere in the city and get alcohol. But if I needed to get to the doctor's office or some other vital place to my routine preventive health care, that was, maybe miles away, where alcohol outlets and even you think about CVS, Walmarts, all of those are access points for alcohol. But in the state of New Hampshire, we pride ourselves on our alcohol sales because that's how we make money. And for those of you who will be going through toll booths, today, you can stop and get as much alcohol as you want right there at the liquor store, right? So we pride ourselves, but it also does tempt our population, and we are seeing, again, not exactly a flat line, a slight increase in alcohol use. We know that alcohol use is tied to some of these cancers, especially at an excessive level. So yet again, another place where we need to think a little more smartly about it. What else could we be doing to kind of curb this before it amounts to someone excessively using? So, a few more slides. Promised I wasn't going to PowerPoint you to death. So this is an important one. It's what I talked about before, about the stage of diagnosis. So this is just a smattering of cancers, not all cancers. And certainly the green is where we diagnose in the local stage or even in an in situ stage. That's where we optimally want to be. Unfortunately, some cancers are harder to diagnose earlier, or when I think of esophageal cancer, a lot of people who end up getting diagnosed with that get diagnosed later in the disease process because the signs and symptoms really don't develop early on. And when they develop, people chalk it up to other things, like acid reflux or other things that make it uncomfortable, and they're not thinking that that actually could be a cancer forming in their body. By the time they actually go and get checked, it's often spread throughout the body. So that kind of attributes to why that's at a later stage. But I bring it forward because we obviously want to encourage people to get screened as early as they can. This is a great little grid. I think everybody should have one of these in their lives. And it kind of plots out by age which cancer screening you should have when. It's kind of like the immunization schedule for children. We all should be embracing this at some level. But let me start to end with the determinants of health that are so often missed. These are really important. So having a sense of purpose in your life adds 7 years of life expectancy. Having a sense of purpose. So I don't know if you all have a sense of purpose. Maybe you do. I sometimes question mine. I think when I survived cancer, I really, I had to face my own mortality. And I'm like, what am I doing here? How am I spending my time, right? So other things that we don't talk about is that importance of social connectedness and the disconnect, excuse me for 1 second. Sorry. Is similar to smoking 15 cigarettes a day when we're not connected socially. Really important. Faith and believing. Now, I'm not going to get all religious on you. I'm just saying we all have to believe there's something bigger than ourselves. And by doing that, by just having some form of believing in something bigger than ourselves, and even religious practice, by going to some religious practice, even 4 times a month, it can add 4 to 14 years of life expectancy to your life. And it kind of gets at to the gratitude point you made. When we live gratefully, when we live holistically, we live healthier lives. So I'm going to start to end with this. What's really important when we think about the antidote to adversity, it's resilience. And this is some of the research that Dr. Andrew Schatt has put out. He's done a bazillion TED Talks. I use this quite frequently because I often think about my cancer experience when I look at this sort of bullseye. So the center of the bullseye, and you'll meet people like this in your life, you may even have family members, is really about me, woe is me, I'm the victim. When I was diagnosed with cancer, I could have been the red dot. I could have been like, this sucks, I got cancer. I will tell you, when the surgeon told me that I had cancer, I dropped an F-bomb, and I said, I don't have time for this stuff. And I just looked at her, I'm like, this is not going to be my life now for 2 more years. I can't do this. I've got kids to raise, I'm working, I'm not going to fit this in. This is ridiculous. When we step outside of ourselves, though, and this often happens when I'm dealing with people who are struggling in the community, especially living in poverty and other places, I see them sort of inwardly focused. When they start thinking a little bit further, like about their family and their friends, that's when we start to see resiliency shift to where we want them to be. And then also that outer ring. So when we get to the point of people who are thinking about community, people are thinking about the greater good, who are constantly thinking about something bigger than themselves, actually live longer, healthier lives and have more resiliency when they need to face adversity like cancer. So I'm going to jump and kind of get us to questions. So just a point of the 65 and older population, it should cause us to ask ourselves, are our communities age-friendly? And then certainly I want to support our cancer caregivers. I'll just end with one of these quotes from Rosalind Carter, which is one of my favorite quotes. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. I love that. We don't often think about the health of caregivers, but we have to factor that in. And then reflection, I hope I leave you today with your own inward look at things to say, what's my sense of purpose? What can I do in my spheres of influence to prevent future cancers in the state of New Hampshire? And even among my family and friends, and we keep it personal, it keeps us motivated. And what's one thing that you could leave today to actually change? And I'll tell you, Dr. Waldenberger, in The Science of Happiness, said, I want you to leave today, and I want you to text, email, or call someone you have not spoken to in a while. That one act is already going to boost your happiness and your health. But I challenge you to do that today when you leave. Take a moment, or even if it's someone you don't know very well and you haven't checked in on them. It could be somebody who works at your bank. I don't care. Take a moment to really be there for someone else. That is going to be good for your health. Okay, we're going to jump to questions now, and we have to wrap up. So I am going to see if someone can read this to me. I'm going to, what about vaping? Yes. Yes, similarly, I'm going to kind of turn myself around. I'll go this way. How's that? I don't want to put my back to you, but either way. Okay, so vaping, we certainly know, especially among young people, has been a newer trend. And it doesn't, we've seen stretches in the research about Does vaping have